Hello, welcome to today's presentation, TAVR, a modern option for heart valve care, presented by Dr. Ramin Beygui, Professor of Surgery at UCSF and Medical Director of the Cardiothoracic Surgery Program at Washington Health. Dr. Ramin Beygui is a cardiothoracic surgeon who performs heart and lung transplants, as well as heart surgeries, such as mitral valve repair. In addition to adult patients, he cares for pediatric patients who need heart or lung transplants or treatment for birth defects of the heart. Dr. Beygui received his medical degree from the University of California, Irvine School of Medicine, where he was a Regent Scholar, and then completed a residency in surgery at Stanford Medicine. He completed a fellowship in cardiothoracic surgery at the David Geffen School of Medicine at UCLA, as well as fellowships in endovascular surgery and vascular surgery at Stanford Medicine. Dr. Beygui is a fellow of the American College of Surgeons. He is a member of the American Association for Thoracic Surgery, the Western Thoracic Surgical Association, Society of Thoracic Surgeons, Society for Vascular Surgery, and American Heart Association. He serves on councils for the International Society for Heart and Lung Transplantation. Please welcome Dr. Ramin Beygui.
Thank you very much for the introduction. I was going to discuss the aortic stenosis and various treatment options for aortic stenosis that includes transcatheter aortic valve replacement or TAVR. What is aortic stenosis? A little bit of a basics. Aortic valve exists between the aorta, which is a major blood vessel in our heart, coming off the heart to the rest of the body, and the left ventricle. Narrowing of the valve and tightness of the valve can afford problems for the left ventricle in order to be able to push the blood from the ventricle towards the aorta. If the aortic valve stenosis is more severe, then it can cause symptoms and problems for the patient. Most of the time, the aortic stenosis is caused by buildup of calcium. As you can see on the top picture, the aortic valve opens properly when the heart beats, and it relaxes and closes when the heart relaxes. But if there is an aortic stenosis, then the valve will have a hard time opening completely, and sometimes even has a hard time closing properly. So it can both cause tightness of the aortic valve and the leakiness of the aortic valve. If there is some leakiness of the aortic valve or the severe tightness of the aortic valve, then the heart has to work a lot harder to be able to push the blood past the area of the tight opening. This can worsen over time, and patients may develop symptoms. So the question is the aortic valve stenosis serious? Well, it is a serious problem. 2.5 million people over the age of 75 in the United States suffer from aortic stenosis. Not all of them are severe or symptomatic, but the diagnosis can be made. The aortic stenosis is progressive. At the beginning, it could be mild and not cause much problems for the patient, but over time, the stenosis can become worse and tighter. If you look at this picture here, you can see in a normal valve, in a depiction of the aortic valve opens up properly and it closes properly. However, when the valve is diseased, and most of the time by buildup of calcium, the valve doesn't completely open when it's supposed to open, and sometimes does not completely close when it's supposed to close. So it's tight, and the heart has a hard time pushing the blood past the valve, and also doesn't close, and as a result, it leaks back towards the valve. So this diagnosis requires a medical diagnosis. Your doctor, your physician, or even somebody else can hear a murmur in your chest that may indicate that there is some tightness of the aortic valve, but we don't know what the degree and the severity of the aortic stenosis is. So usually some medical tests are done to diagnose that. Over time, as if somebody is exercising and the arm muscles can get bigger and stronger, over time the muscle of the heart can become thicker as it's trying to push the blood past the area of stenosis, and it becomes thicker. So if the heart gets thicker, this chamber where the blood is becomes a little smaller, and then the heart will have a hard time pushing the blood past the aortic valve into the aorta, and as a result, the patients can develop symptoms of chest pain, fatigue. Also, I can have difficulty breathing, shortness of breath, or syncope, which is fainting or near fainting. Sometimes they have a hard time standing up from a sitting position before they get the patients get lightheaded or nearly faint. Aortic stenosis is a very common disease. More than 200,000 new cases of aortic stenosis are diagnosed everywhere in the United States. But as you can see on the slide on the right side, some 40% of these patients may go untreated. So approximately 160,000 people in the United States annually get treated for aortic stenosis. So it's a very common operation and is a very common diagnosis. Treatment is usually medical or surgical and is treated by cardiologists or cardiothoracic surgeons and cardiologists jointly. One of the most common valve diseases is aortic stenosis. Mitral valve, which is another valve in the heart, could also be diseased, and a little bit more common to have leakiness of the mitral valve. But nowadays, the aortic stenosis is frequently diagnosed and is treated. It always requires some sort of an imaging. Usually an echocardiogram of the heart will indicate that the patient has aortic stenosis, the severity of the aortic stenosis, and whether we need to treat it or not. Echocardiogram is a non-invasive test, does not require radiation, does not require invasive procedures, and it can be done in one afternoon or even shorter in the hospital or in your cardiologist's office. Aortic stenosis is also chronic. It can last for many years and the patients may not be aware of it or may not have any symptoms, but then it gradually gets to the area that the valve could become symptomatic or the severity of the valve increases. So if you look at my slides here, about a third of the patients, 29% of the patients over the age of 60 may have some degree of aortic stenosis. As I mentioned before, only about 60% of the patients with severe aortic stenosis, symptomatic or asymptomatic severe aortic stenosis, may get any treatment at all. Approximately 50% of the patients, untreated adults, they will have, they may not live more than a year or two, and sometimes no more than 5 years, even if the diseases are relatively mild and moderate, and then gradually progress to severe stenosis. If a 60-year-old person gets treated for aortic stenosis, they can expect to have a life expectancy of 20 years or longer. So treatment does enhance patients' longevity and survival. So it's good to diagnose this aortic stenosis and treat it as soon as they are diagnosed or as soon as the patient is ready for treatment. So what are the symptoms of aortic stenosis? As I mentioned before at the beginning, the aortic stenosis could be asymptomatic for many, many years, and the patients will gradually develop symptoms. As I mentioned before, the mitral valve also is underneath the aortic valve. So if the aortic stenosis is severe and the ventricle becomes large, then also the mitral valve could start be leaking. So you have symptoms of both the aortic valve and the mitral valve. The patients may present with chest pain because during exercise or when the heart tries to squeeze really hard to push the blood past the aortic valve, it can overcome its own blood supply and the patient may present chest pain. Sometimes, as I mentioned before, the ventricle itself becomes small, and if the volume of the blood inside the heart is small, then the patient can have fainting or lightheadedness. If the aortic valve stenosis progresses, then the patients may develop heart failure. Symptoms of a heart failure could be swelling in your ankles, having difficulty lying flat, very symptomatic shortness of breath, and difficulty doing regular activities of daily living. Patients can also develop arrhythmias or palpitations, but shortness of breath and fatigue are very, very common, one of the earlier signs of aortic stenosis that are severe. Patients may also think that they cannot engage in their regular activities, like walking a flight of stairs may be difficult, or walking flat surfaces would be difficult, and they would avoid those because of the aortic stenosis, because patients get tired. So as you can see on the slide on your right, the patients can develop syncope, which is near fainting. They can have chest pain or shortness of breath. Interestingly, also they can develop easy bruising. As the blood passes this diseased aortic valve, some protein in the blood can become damaged. As a result, the patients can have easy bruising. So that would be one of the symptoms of aortic stenosis, which is called the Hyde syndrome. So what are the risk factors for aortic stenosis? Well, one of the main risk factors is age. As we all get older, the risk of aortic stenosis does increase. As I mentioned, people over the age of 60, about 30%, 29 to 30% of them could have aortic stenosis, and about 2.5 million people in the United States over the age of 75 have aortic stenosis. Some people are born with abnormal aortic valve. Normally, the aortic valve has 3 leaflets. So if you look at it in cross-section, a lot of times it looks like a Mercedes-Benz sign. But some people are born with the aortic valve that have 2 leaflets called the bicuspid aortic valve, or even more abnormal, the unicusp, one aortic valve. So those patients in general are prone to having aortic stenosis a little bit earlier in their life and at a younger age. Calcification of the aortic valve is normally very common in patients, and it can lead into aortic stenosis. So people who have a tri-leaflet aortic valve basically are born with a normal aortic valve, over time can develop calcification of the valve that it can lead into aortic stenosis. Rheumatic heart disease in childhood later on in life can result in aortic stenosis. Most of those patients may have mitral valve stenosis, which is another valve in the heart, but also they can have aortic stenosis. Patients who have chronic kidney disease or on dialysis, because there is some abnormality of the metabolism of minerals, specifically calcium, they can develop early aortic stenosis or mitral stenosis as well, which is another subject for discussion. So these are the main risk factors for aortic stenosis. Overall, though, there are some people who have none of these risk factors. They could be younger, they could have no problem with chronic kidney disease, and they would not have any history of rheumatic heart disease, but they develop aortic stenosis and calcification of the aortic valve, which we don't know for sure why. Some people develop it and some people don't. And there are also a lot of older patients who have no aortic stenosis at all. So just being a little bit older in and of itself is not a particularly one-on-one risk factor for developing aortic stenosis. A little bit, just a brief discussion of the anatomy of the aortic valve. So if you cut the aorta, which is the major blood vessel coming off your heart, open, then you see there are these three fine leaflets within the aortic valve itself. And the blood supply to the heart, called the coronary arteries, come off the left and the right leaflets. But then on the slide on the bottom, you can see that some people are born with the aortic valve that kind of looks like a little bit like a fish mouth deformity. And then instead of having these leaflets open up properly, they fuse together. These patients are in general more prone to develop aortic stenosis and aortic calcification. And sometimes over time there's a fusion between the two leaflets, and the patients are also more prone to aortic calcification that eventually will result in aortic stenosis. On these picture depictions, you can see that the valve has a very hard time opening and closing. Normally they are very fine, thin leaflets that it can open and close, but with the calcification they become hardened and the valve doesn't properly open. Akin to a door that it doesn't open properly, so the breeze has a hard time going in and out of the room. Here with the aortic valve, the same thing can happen, and the blood cannot easily get out of the left ventricle in and out. And then I alluded to it before, over time, if this aortic stenosis persists, the patients can develop heart failure. This left ventricle of the heart can become enlarged, and it can pull on these chordae that are attached to a different valve called the mitral valve. And then the patients can also develop regurgitation or leakiness of the mitral valve. So the mitral valve is sort of an innocent bystander. In and of itself is not disease, but because the ventricle became sick because of the aortic stenosis, now the mitral valve is also leaking. So in those patients that have leakiness of the mitral valve, which is otherwise normal, but the aortic valve is stenotic, is tight, then just treating the aortic stenosis will make the mitral valve better as well. So treating one valve will result in the resolution of the problem of the second valve. This is sort of another depiction of the same thing, that even patients with a normal tri-leaflet valve have calcification. As you can see, the hole inside the aorta is very small and the blood has a hard time coming in. People who are born with a bicuspid aortic valve have a slit instead of a natural circle in the middle of the valve, and they also form early calcification early on. And the valve can gradually develop these areas of calcification on the leaflets that at the beginning the leaflet is still open and closed, but over time it can progress to a picture like this. So let's talk a little bit about the natural history and progression of the aortic stenosis. So we are all born, let's say, with a normal aortic valve. The valve opens and closes properly. Over time, there could be some sclerosis, which means scarring of the aortic valve, but the valve still opens and closes properly. So those patients have no symptoms, and the valve area is still large, and they have no aortic stenosis. Over time, this calcification can form, and the leaflets have a harder time opening, and then you can develop mild aortic stenosis. It can progress to moderate, and then to severe, and then sometimes to critical aortic stenosis. These severe and critical aortic stenosis are the ones that we usually treat. Also, some people with moderate aortic stenosis with some other concomitant conditions may be treated earlier to avoid progression to the severe disease or the complication of severe disease. So symptoms usually signal advanced disease, meaning that the patients could have aortic stenosis and they have no symptoms, but then over time they gradually develop symptoms. Symptoms are angina, which means chest pain, syncope that I alluded to it before, which is fainting or near fainting, and if the aortic stenosis progresses for a long time, the patients will develop heart failure, which means they have severe accumulation of fluid in their lungs, severe shortness of breath, and also swelling of the lower extremities. And if the symptoms progress, the patients may not live more than 2 to 5 years at the most. Heart failure is the worst because then, about half the patients may not survive more than 2 years. And angina is the milder symptoms, and half the patients may not survive more than 5 years without any treatment. But fortunately, there is a treatment for it. So if the patient has mild disease and is diagnosed by echocardiogram by a cardiologist or a primary care doctor, they can be monitored and they can be given medications to monitor the blood pressure and all the other risk factors. And for a long time, they may remain asymptomatic and the aortic stenosis can still remain mild. But if they have developed a severe aortic stenosis, then the valve replacement is the only definitive option. Why is that? Aortic stenosis is a mechanical problem. A valve on the heart is tight and the blood cannot get from the heart to the rest of the body. So replacing and removing that valve, or now with the newer technology, replacing it without removing the valve with the TAVR is the only option. So there are two approaches. One is called the surgical aortic valve, that I may refer to it as SAVR, S-A-V-R, which requires open chest surgery. Technically, we are not opening the heart when we operate on somebody for aortic valve, but most of patients will refer to it as open heart surgery. We are actually opening the aorta to replace the valve. And then there's a transcatheter aortic valve, which more or less is subject of our conversation today, which is a minimally invasive approach to treat the aortic stenosis. So what is a TAVR? TAVR stands for transcatheter aortic valve replacement. As I mentioned before, if you want to replace the aortic valve, the patient has to go under anesthesia, open the chest, open the aorta, remove the valve, and then put a new valve in there and close the aorta and close the chest. But transcatheter aortic valve is a newer technology, would allow us to enter the aortic valve from a site remote from the aortic valve, usually from one of the arteries in the groin, that we don't even have to expose it or dissect it out or do a surgery. We can just identify it and then do a puncture access and introduce the valve into the aorta and put it in position under fluoroscopic control. So this picture shows that the valve is delivered from someone's artery in the groin called the femoral artery, is positioned across the aortic valve, and then in this particular case, there's a balloon that is dilated and allows the valve to expand, and by friction remains within the aortic valve, and then the rest of it is removed and the valve remains in place. There are also other valves that don't necessarily require a balloon placement, that they can self-expand and remain in position. So technology in this field has advanced and will continue to advance. So I was wondering if I could share this animation with you. This is from one of the valves that we are using called Edwards, which is a balloon expandable valve. In this particular animation, you see that first, because the aortic valve is severely stenotic, a balloon is introduced from the artery in the groin across the aortic valve. The balloon is expanded. So now the valve is a little bit open, and that sometimes can result in the leakiness of the valve because we have not really replaced the valve. We just push the calcium aside to allow the valve to get across it. Now the valve is introduced with the balloon on it. The balloon is brought into the aorta below the valve, closer to the groin, and the balloon is loaded into the valve which is mounted on it. In this particular position, the valve is not expanded yet, so it's in low profile state. So you can sit within that blue catheter, which is sort of a tube that comes from the groin towards the aorta. Now the valve is under fluoroscopic control, under X-ray is delivered across the valve. You can see it just comes across the valve. We position it in place right here. We don't see the aorta, but we use X-ray and echocardiography to make sure the valve is in the right position. In this particular picture, you can see also there are coronary arteries, which is a blood supply to the valve. We make sure here there are little orifices where the blood supply to the valve is. The valve is described as calcified. We make minor adjustments to the position of the valve, and then we use the balloon to expand the valve. Once the valve is expanded, it should be functional immediately. We pull the catheter back through the groin, repair the artery in the groin most of the time without doing any surgery on the aorta, and the valve is already in place. So the question is now, who is eligible for transcatheter aortic valve replacement? At the beginning, when we were first evaluating this new technology of transcatheter aortic valve, we wanted to compare it to the surgical aortic valve. So we looked at the very high-risk patients or prohibitive risk patients, and then the results were favorable for both the transcatheter aortic valve and the surgical aortic valve. And then we looked at the intermediate risk patients, the patients who have an intermediate risk of having complications from an open chest, open heart operation. And still the transcatheter aortic valve was favorable and appeared to be in par with surgical aortic valve replacement. And then subsequently, we compared the patients who are at low risk for surgery and to see if the transcatheter aortic valve would be an option for them. And even in those situations, it seems to be favorable. So in general, patients with symptomatic severe aortic stenosis are good candidates to undergo transcatheter aortic valve replacement. Currently, not exclusively, majority of the patients who undergo transcatheter aortic valve replacement tend to be a bit older than the age of 75 or so, mainly because we think that the risk of surgery is still a little bit higher for those patients, and the surgery in those patients may not be as easily tolerated as the transcatheter aortic valve is tolerated. Many patients who have had prior heart operations before may not be a very good candidate for another operation on their heart, and therefore transcatheter aortic valve becomes a very good option for them. For example, let's say someone has undergone coronary artery bypass grafting decades ago. Now they have developed aortic stenosis. Instead of reoperating on them and opening the chest again and putting them on a heart-lung machine and replacing the valve, with the transcatheter aortic valve, without doing any of that, we can replace the valve properly. Some patients have already had an aortic valve done years ago, 10 years ago, 15 years ago, many years ago. And now this aortic valve is not working anymore. It has degenerated again. So those patients are in general a very good candidate for transcatheter aortic valve replacement, that it can be done in those patients. In general, patients who have those bicuspid aortic valve, they tend to be a little bit younger, or they have some concomitant disease like coronary artery disease or aneurysm of the aorta, or some other issues that needed to be addressed surgically. We still consider surgical aortic valve replacement. For example, if the patient has left main coronary artery disease and we are planning on doing an operation for the coronary artery disease for that particular diagnosis, and they're also diagnosed with aortic valve stenosis, so surgical aortic valve replacement concomitantly with other operations are very reasonable, whether it's a coronary artery bypass grafting, mitral valve operation. So there are conditions that the patient is undergoing surgery, which is incidentally, they are found to have also aortic stenosis. Aneurysm of the ACN aorta, and as I mentioned before, most of the patients who are younger and have a bicuspid aortic valve, they seem to do well with the surgical aortic valve. However, transcatheter aortic valve replacement is always an option, and the patient will be fully evaluated. Even some patients who are asymptomatic, but they show signs of heart failure, the heart's beginning to distend and is thicker, they would be a reasonable candidate for aortic valve replacement, especially for transcatheter aortic valve replacement. And if the aortic valve stenosis is really critical, if the aortic valve area is under 1 centimeter squared, it's usually considered to be severe. But if it's less than 0.6 centimeters, it's usually considered to be critical. So those patients, even with symptoms or small amounts of symptoms or without symptoms, would be considered surgical treatment. A little bit about symptoms. Some patients may consider themselves to be asymptomatic. As I mentioned before, they can also avoid activities that they like. In those patients, avoiding activities like climbing stairs or going for a walk or taking your dog for a walk and doing things along those lines are actually symptoms. So people tend to avoid activities even if they are not unaware that they have aortic stenosis. And a lot of times they attribute it to the older age or getting tired and fatigued and older because of that. But in all likelihood is from aortic stenosis. And treatment of aortic stenosis can reverse those problems. So now a quick comparison between the surgical aortic valve replacement or SAVR and transcatheter aortic valve replacement. Well, surgical aortic valve replacement usually requires an incision in the chest. Sometimes we can make those incisions very small, not particularly invasive. However, the transcatheter aortic valve usually is done through a small puncture in the arteries in the leg, which is still smaller than a small incision on the chest. Anesthesia for a surgical aortic valve is general. The patient has to be completely asleep to be undergoing a surgical aortic valve replacement and placed on a heart-lung machine. But for a transcatheter aortic valve, they're usually under light sedation. They don't require general anesthesia. Heart-lung machine is needed for surgical aortic valve replacement and is not needed for transcatheter aortic valve replacement. And hospital stay for the surgical aortic valve replacement has improved, but it's still usually about 4 to 7 days by the time the patient is ready to go home. For transcatheter aortic valve, great majority of the patients go home the next day. You don't have to stay as much. Recovery at home is usually for surgical aortic valve replacement is about 4 to 6 weeks for the bone to heal and the patient to be back to normal. For transcatheter aortic valve is less than a week and even shorter at times. So what is the outcome of a transcatheter aortic valve, which is from 2024 to 25? The 30-day mortality, the patients not surviving the operation is less than 1%. Greater than 99% of the patients do very well and they survive. The risk of stroke is also approximately 1%. The stroke is when a piece of calcium can break off from the aortic valve and go to an arteries of the brain and cause difficulty with movement or speech and things along those lines. We do everything possible to evaluate the patients prior to surgery, including evaluating the blood supply to the brain and calcification of the valve to reduce the risk of stroke. The major bleeding after transcatheter aortic valve is quite low, less than 5%, and actually in our own experience is less than 1%. The valve durability has significantly improved. In general, we tell patients that they can expect the valve to last 10 years and longer, but that technology is advancing. There are many companies that are working on making the valves more durable and the longevity of the valves to get better. And this outcome continues to improve, both our understanding of the problem and treatment of the patient and improvement in technology and the valve. So what does the patient's life look after a transcatheter aortic valve? Patients in general very quickly would have improved breathing and energy, and their stamina would improve. They have less fatigue. They can rapidly return to their activities of daily living, work, or if they are retired, to activities that they're doing as part of their recreation. Most patients are home within 48 hours, and cardiac rehabilitation is often recommended, but is not as required because the patients have not undergone a major chest operation or heart-lung machine, so they can get back to their work without a significant period of rehabilitation after transcatheter aortic valve. Just a little bit of orientation or introduction to our team is Dr. Harsh Agrawal is one of our interventional cardiologists. Dr. Agrawal and myself and Dr. Lee, who's also another cardiac surgeon, we work together at UCSF, and now Dr. Agrawal is working full-time at UCSF Medical Center. In addition to working with us closely on treatment of aortic stenosis and transcatheter aortic valve, Dr. Agrawal is also very facile in treating other conditions of the heart without requiring an open heart operation, such as mitral valve, placement of Watchman devices into left atrial appendage. Dr. Lee and I are cardiothoracic surgeons. We both work at UCSF and also at Washington Hospital. And also Kelly Franco is our nurse practitioner who works coordinates the care of our patients, both preoperative and intraoperative and postoperative care of our patients. We also have imaging specialists at Washington Hospital who look at the patient's aortic diagnostic imaging, including CT angiogram of the chest, echocardiogram. We also have dedicated cardiac anesthesiologists and nursing staff who only take care of cardiac patients. We have a 24/7 intensive care that requires 2 of our intensivists to be there all the time. But interestingly, great majority of our patients who undergo transcatheter aortic valve do not require admission to the intensive care, as opposed to the surgical aortic valve that usually requires admission to the intensive care unit, at least for 24 to 36 hours. So at the Washington Hospital, our transcatheter aortic valve site has been recognized as one of the major centers for treating valvular heart disease and other procedures. We have advanced imaging and procedural capabilities to take care of these patients. Through Dr. Lee and myself, because of our collaboration with UCSF, we can see and evaluate the patients and provide the majority of their care here at Washington Hospital. For the services that we may not provide, like advanced heart failure may require heart transplantation, lung transplantation, or usage of the mechanical circulatory support, we facilitate the transfer of the patients to UCSF Medical Center, and we collaborate with our colleagues over there. But overall, overarching issue is a great majority of the cardiovascular problems, whether it's aortic stenosis or other concomitant heart diseases, we can take care of the patients here at Washington Hospital. With that slide, I thank you for your time and attention. I'll be happy to take any questions.
Thank you, Dr. Beygui. Our first question is, what makes a patient a good candidate for TAVR versus open heart surgery?
Thank you very much. That's a very good question. In general, as I mentioned before, the transcatheter aortic valve was first evaluated for high-risk patients because the results of surgical aortic valve replacement were quite good. But over time, we understood that even patients with that lower risk or intermediate risk are good candidates for aortic valve replacement. At this point, majority of the patients who undergo transcatheter aortic valve replacement appear to have a trileaflet valve, not a bicuspid valve. They appear to be a little bit older, perhaps over the age of 75, and younger patients in general undergo surgical aortic valve replacement. However, that formula and that equation can change in the future as the transcatheter aortic valve becomes more durable. If the patients have concomitant issues with the coronary artery disease or aortic aneurysm, in general, we'll consider them for surgical aortic valve replacement to treat all the problems at the same site. But as I said again before, we'll fully evaluate the patients to see if indeed the transcatheter aortic valve is a good option for them.
How long does a patient need to stay in the hospital after a TAVR procedure?
Well, in the past, the patients would stay, as I showed in my slide, less than 48 hours. Now, great majority of our patients, the procedure is done without general anesthesia. The patients go into the recovery room. They do not require admission to the ICU. We monitor and watch them overnight. The next day, we'll get an echocardiogram and they can go home the next day. So less than 24 hours. Great majority of the patients will be discharged from the hospital and then they can go back to their regular activities.
What does recovery look like for someone who has a TAVR procedure?
TAVR procedure, because it's a much less invasive procedure, usually just an access through an artery in the groin, the patients require quite quickly. By the time they go home, the next day after the operation, they sit in a car, they go home with the family members, they don't have to avoid strenuous physical activities, and they can return to activities of their living immediately. Surgical aortic valve replacement, on the other hand, will still require some period of healing of the bone of the chest and some recovery at home. So the recovery from transcatheter aortic valve is quite fast, as early as the next day after surgery, and sometimes within a few days.
This concludes our program. Thank you, Dr. Beygui, for this insightful presentation. And thank you, viewers, for tuning in. The entire broadcast of today's presentation will be available on our YouTube page.